are there patients that we've potentially cured? And I think of all of the breast cancer subtypes, this is probably that subtype that we might be using the C word. And, we have induction trastuzumab, pertuzumab with taxane, followed by maintenance. Trastuzumab, pertuzumab, we tend to then, for those with ER-positive, HER2-positive breast cancer, incorporate endocrine therapy, which actually wasn't allowed initially in the Cleopatra trial. And we have many patients that really do quite well with it and tolerate it well. And, we saw overall survival data, and we had a number of patients that still continued on at the final analysis. And so that has been the first line, standard of care for over a decade.
Yeah. Can you comment on sort of that tail that we see with just antibodies?
Yeah.
Because, again, to sort of introduce the new trials in that sort of context.
Yeah. I believe as far as out of like 8 years or so, there was 37% of patients that were still on and still alive at that time. And you still have that tail of patients. And we've all, I'm sure, have these patients in clinic where they continue on trastuzumab, pertuzumab. And the question is, do we stop? And now we're designing these studies like the Stop HER trial to determine, are there patients that we've potentially cured? And I think of all of the breast cancer subtypes, this is probably that subtype that we might be using the C word. And so definitely a tail, which then with newer data, that really kind of shakes the landscape a bit.
Yeah. Do you think, what do you think are unmet needs in that setting, considering Cleopatra?
Right. So I think, for patients who have a short disease-free interval, right? So if they had received like a taxane, trastuzumab, pertuzumab in the neoadjuvant setting, and then have a short disease-free interval to metastatic disease, then we tend to not want to use a taxane-based regimen in the first-line setting. I right now tend to go to TDXD in that space, especially in patients who've had, TDM1 in the adjuvant setting. I think the other is some of our patients do have neuropathy after, like docetaxel, carboplatin, trastuzumab, pertuzumab. And then they might get TDM1. And then when you come to the first-line setting, giving a taxane, there's issues there. And then the other, I think the big one is CNS involvement. And so we definitely need therapy options that have good CNS penetration. We don't really see a lot of that with THP or patients who have really high, visceral burden, visceral disease burden. I think those are areas of unmet need. I could go honestly on and on. I think those are the keys.
I agree with you. The question then is, knowing that we have patients who have done so well on Cleopatra, patients who are still on antibodies for a long time, when we're thinking of new trials, again, we don't cure everybody. In fact, we hardly mention the C word in that space.